All right, good afternoon, everyone. Let's go ahead and start for today, April the 3rd, and it's just about 3:30 p.m. here. So, what are some of the things that we have to be reminded of? Uh, I've sent out your study guide for your lab exam coming up this coming Saturday, and hopefully you would have received it by now. If there's anyone who has not, please feel free to email me so I can go ahead and send that back to you. That would be your lab practical number 2. Um, and all the logistics and the format have been described there. It's pretty much the same as what you did for your first one. So not many differences there. Only you have 90 questions this time around and 120 minutes to finish those on your Connect website. Um, Also your Connect quizzes, just a reminder that they're there for your taking, so please make sure you're keeping up with those as well. Case studies, something that I talked about earlier. Um, and then I am working on your study guides for the remaining exams, and that way I should be able to send those out in good course of time as well. Okay, so I believe those were all the reminders that we have. Of course, keep turning in your lab work, and I will be updating your grades by tomorrow. So please make sure you're able to share your work with me before the deadline runs out, which is tonight. Okay, so here we are on slide number 99, and chapter 26 is where we are at, having to do with the GIT, which stands for gastrointestinal tract. And some of you pointed out how uh, my voice got cut out for the last few moments of our lecture last time, so I appreciate that, and I realized it afterwards as well. However, there was nothing that was really missed during those final moments. So, and you did receive the picture of my notes that I took. So we are all good in that regard. And going forward, I will be more careful here. Make sure that I don't hit the mute button or something like that when I'm demonstrating one of those physical examination techniques. All right, so slide 99 on chapter 26. We're talking about peptic ulcers. So what is an ulcer? It's a break in an epithelium, a wound, uh, a break, or any lesion that exposes your insides to the outside environment. Okay, that's an ulcer. Peptic refers to the fact that these ulcers could be found either in your stomach, in which case they're called gastric ulcers, or in your small intestine, where they're called either duodenal ulcers, because duodenum is the first part of your small intestine. Okay, so taken together, they are called peptic ulcers. So what causes the formation of these ulcers? So first up, advancing age in itself is a risk factor, because as you get older, your mucosa of the stomach lining thins out, pretty much like all the other organs. So your chances of developing an ulcer increase. On top of that, about 95% of patients who develop peptic ulcers happen to be infected with the type of bacteria. And that's interesting, a bacteria causing peptic ulcers, or at least playing an important part in the development in the pathogenesis of peptic ulcers, and that is called the Helicobacter pylori bacteria, as you can see here. Okay, so this was something that was found out later on, that a fair number of people who develop peptic ulcers are infected with H. pylori in their GI tract. What are some of the signs and symptoms? So again, risk factors of H. pylori infection, advancing age, genetics. If you have first degree blood relatives who have suffered from peptic ulcers, you automatically have a higher risk. No specific diet has been linked to the development of peptic ulcers. However, of course, any food that induces gastric juice secretion or acid secretion like caffeine, or spicy foods, um, in some circumstances, they would lead to an aggravation of the ulcer. They do not cause ulcers per se, but if you're already predisposed to developing ulcers, they can make it worse. And then drinking milk, of course, has been touted as one of the uh, cures for peptic ulcer. It's technically not a cure, but it will help with some of the signs and symptoms like the pain and the gnawing sensation in the epigastrium. And how milk does that is because milk is alkaline. So it's going to neutralize the acidity of the stomach acid. So the signs and symptoms certainly simmer down. It's not a treatment again. So milk is for symptomatic treatment of peptic ulcers, right? So, all right, milk ingestion and peptic ulcers. Also stress, again, chronic stress is something that will cause hyperacidity. And especially if you're hungry for long periods of time and stressed at the same time, then that can also predispose you to the development of peptic ulcers, all right? Okay, so signs and symptoms, epigastric pain, and it's postprandial. Postprandial means after meals, okay? Preprandial, of course, is before meals. So postprandial epigastric pain is a common sign, or a symptom rather, that you would experience nausea, vomiting, indigestion. Sometimes it's so bad that people would literally gag themselves, right? Put their fingers inserted in their mouth and try to throw up to get rid of that. So not a recommended way of uh, for preventing anything there, okay? If anything, it can make it worse, cause more acid reflux and more burning, including your esophagus as well. So how you treat it is, again, by means of the same drugs that are used for gastric reflux or acid reflux, right? So those would be antacids like Maalox, uh, Pepto-Bismol, Rolaids, all of that. Also H2 blockers like cimetidine, ranitidine. Those are some of the drugs used there, or proton pump inhibitors like lansoprazole and omeprazole. Nexium, the purple pill, we talked about that one too. One of the dangers here with peptic ulcers is if continue to grow unchecked, they can actually perforate. And again, as you age, that risk increases. So uh, now the lining of your stomach is so thin that it cannot withstand the burning, the caustic action of the acid anymore. So a tiny ulcer might actually perforate, and that is disastrous because now you have the acidic contents of your stomach pouring out into your sterile peritoneal cavity. So what do you develop now with the perforated peptic ulcer? Peritonitis. And as we mentioned before, peritonitis is an acute surgical condition. You have to get this patient to a general surgeon and onto the operating table as soon as possible, or this person is going to die because of widespread infection. Think of your stomach acid burning its way into all of your intestinal, all of your digestive organs in your abdominal cavity. So that's what we're trying to prevent here. Vomiting, of course, is something that we can also call antiperistalsis, which means your GI tract starts to contract in the opposite direction. So instead of food going down, it starts being regurgitated, right? And you have the vomiting center located in your brainstem, like all the other centers that we've talked about so far in the medulla oblongata. And when they get activated, then you develop the gag reflex and then the following vomiting, okay? And so what happens there is your epiglottis closes the trachea, your glottis closes the nasal passages, and then your abdominal muscles contract violently, and that would basically make you expel the contents of your stomach, right? That's what vomiting is. And as we see here, there's always a danger of aspiration. We talked about how patients who are comatose or unable to move in the medical ICU as an example, uh, they are at high risk for aspiration pneumonia because they can actually aspirate the gastric contents into their lungs, okay? That's something you have to prevent, something important to remember. And vomiting can actually tell you a lot of things about what's going on with the patient. For example, you might have someone displaying projectile vomiting, right? What does that mean? The vomitus literally shoots out of the mouth with some force, and it would like fly to some distance rather than just dribble out of the mouth. So projectile vomiting can tell you a lot of things. For example, in meningitis, right? Acute meningitis and projectile vomiting is a common presenting sign of that. Also, uh, obstruction, so intestinal obstruction. A child who has swallowed a foreign object and it's obstructing the esophagus or the stomach or the small intestine, projectile vomiting is what you're going to see. We also talked about pyloric stenosis, as you remember, in infants, right? Which is type of an intestinal obstruction, stenosis. narrowing of the pyloric sphincter, they will display projectile vomiting as well. Who else? Uh, Meningitis, intestinal obstruction, pyloric stenosis, increased, maybe even intestinal tumors, right? Um, any mass which is obstructing the intestines, and you might have projectile vomiting in those circumstances as well. So that's quite diagnostic of these conditions. Not diagnostic, but indicative of these underlying conditions. Then we might have things like what is called coffee ground vomiting. And it's called coffee ground because it literally looks like ground coffee beans, right? This rich brownish color. So coffee ground vomiting is an indicator of gastric bleeding, okay? In other words, bleeding in your stomach. So when blood pours into your stomach, the stomach acid, the hydrochloric acid there, acts with the hemoglobin in blood and breaks it down into this pasty, chocolatey kind of syrupy consistency liquid. And if so, if you're throwing that up, uh, that indicates gastric bleeding. So it could be what? Ulcers, like peptic ulcers, what we just talked about, right? It could be cancer, like stomach cancer, okay, in some cases. Uh, so these are some of the causes to consider when you have things like coffee ground vomiting, or you might have hematemesis, which means bloody vomiting, fresh red blood with vomitus. And hematemesis could indicate a number of things like liver disease, right? Fulminant liver disease, leading to esophageal varices. And I believe I talked about that condition before, how one of my patients, one of the most vivid cases that I remember, had this ongoing hematemesis, bloody vomiting, right? And he had esophageal varices because of liver disease. Or esophageal tears. If you've torn your esophagus because of uh, chronic vomiting, self-induced vomiting in people with like bulimia, anorexia, those kinds of things, esophageal tears, that can cause hematemesis, right? Uh, Such as what are called Mallory-Weiss tears. So these are some things to consider. So yeah, vomiting could be a useful diagnostic or differential diagnostic tool, as we see here, okay? It can be caused due to different reasons. Pregnancy-induced vomiting, something called hyperemesis gravidarum, food poisoning, uh, motion sickness, right? Injury to the head, trauma to the head can activate your vomiting centers. Unpleasant thoughts even, or unpleasant emotions, they can make you nauseous and actually make you throw up. Infection, certain types of food, there's a number of reasons why you might throw up. All right, so what structures are considered part of the upper GI tract, all the way from your mouth down to your small intestine, okay, is your upper GI tract. How is the ingested material referred to as it moves through each of the structures of the upper GI tract? So it turns into chyme, C-H-Y-M-E, semi-digested mushy food, and then chyle, C-H-Y-L-E. What are the roles of the tongue, teeth, and salivary glands in forming a bolus? They all help with chewing the food, mixing it with saliva for both chemical and mechanical digestion, and making it easy to swallow, which is called deglutition. How do the tunics of the esophagus differ from the default tunic pattern in both the mucosa and muscularis? So the esophagus has a type of epithelium called stratified squamous epithelium, okay? Um, and it's more stretchable, more stretchy. That's what esophagus is, more smooth muscle there. How is the bolus moved from the oral cavity into the stomach? So there's the cephalic phase, the swallowing phase, and then this gastric phase. We talked about those, right? List the secretory cell types in the stomach and their products. So we talked about the chief cells, which secrete pepsinogen, right? Which is a protein digesting enzyme. And also we talked about the parietal cells that secrete uh, hydrochloric acid and the intrinsic factor. And intrinsic factor was a protein that is needed for you to absorb vitamin B12 from your diet. Then you also had the alkaline mucus cells and the acidic mucus cells secreting their mucus as well. Which neural reflex is initiated by food in the stomach, and what does it control? So the gastric reflex, it controls the grinding and churning of the food and its passage into the small intestine. All right, so here we are into the lower GI tract organs, okay? So when you talk about the lower GI tract, so everything from the small intestine downwards, all right? So the upper GI tract would be from the mouth down to the end of the stomach, the pylorus, and everything down below from that point onwards, small intestine, large intestine, rectum, anus, those are all parts of the lower GI tract, okay? So the small intestine, as we can see here. Now, interestingly, even though it's called the small intestine, it's actually much longer than the so-called large intestine. Why is it called smaller? It's narrower. The lumen, the diameter of the intestine is smaller, narrower than the large intestine. It's divided into three parts: duodenum, jejunum, and ileum, as you can see here. So duodenum is the first part, which directly receives semi-digested food called chyme from the stomach, okay? And both chemical and mechanical digestion take place here as well in your duodenum, okay? So then you have what are called the accessory digestive organs, and we talked about those before, right? Organs that do not receive food physically per se, but they make important contributions in terms of digestive juices and bile and acids in order to help with the digestion. So that those would be what? Your liver, gallbladder, pancreas, salivary glands, teeth, tongue, all of them. Okay, so they are also active here. And then of course the large intestine, whose primary role is to reabsorb water and some of the nutrients. And your large intestine also has some gut flora and fauna, which means bacteria living in your large intestine that make vitamin B and vitamin K for you, which are extremely important, okay? For vitamin B for your nerve health, for a healthy nervous system, and vitamin K for your blood clotting. And then whatever remains, the indigestible food matter, after all the water has been reabsorbed from your food by the large intestine, that is called the fecal matter, feces now, and that is eliminated from the body. So here in this picture, you can look at all of that, your GI tract. Here's your liver, there's the gallbladder. Those are both accessory digestive organs. Here's the duodenum, the first part of your small intestine, all right? Then here is the jejunum in purple, the second part of your small intestine, and then ileum in reddish color here, which is the last and the third part of your small intestine. Here's your large intestine, the colon. Here's the ascending colon, the transverse colon, the descending colon, the sigmoid colon, and then the anus. So you can see all of those regions here. So this point where you have something called the ileocecal valve is where your small intestine opens into your large intestine, okay? So it's the demarcation between the small and the large intestine, the ileocecal valve, as you can see here. So let's talk about a few disease entities that can afflict your intestines. So together they're called inflammatory bowel disease, or IBD, as you can see. And two entities fit in here: Crohn's disease and ulcerative colitis. Both of these are autoimmune disorders. So in other words, your own immune cells are reacting against your own body, which tells you what? This is primarily a genetic thing. Both of them are a strong genetic component that tend to run in families. Sometimes stress, sometimes certain viral infections can make them worse. But for the most part, they're autoimmune genetic disorders, all right? Some common features that you see in both: ulceration. Ulcers form in your throughout your GI tract. These ulcers are more widespread in Crohn's disease. So in Crohn's disease, they can extend anywhere from your mouth all the way down to the anus. So there is like a complete whole involvement of your GI tract with ulcers. In ulcerative colitis, these ulcers are usually confined to your colon, to your large intestine. Okay, so it's more of a localized involvement with ulcers. What causes it, again, is an autoimmune disorder, okay? And the signs and symptoms: indigestion, pain, blood in your vomitus sometimes, blood with feces, okay? Diarrhea, all of those, flatulence, they go with it. And since these are autoimmune disorders, the treatment, as you would have guessed, is steroids, primarily steroids and other drugs that dampen your immune response, okay? So you have to keep your own immune system in check so that it doesn't attack your own gut. In extreme cases, when the disease is refractory to drug management, it's not responding to drugs, then you have to do surgery. Surgically, you have to remove parts of your intestine because that's the only option left to get rid of the ulceration, the bleeding, and that can lead to anemia, of course, because you're losing large amounts of blood through your gut. So surgery might be the only option in many cases. Then you have something called IBD here, or IBS rather, which stands for irritable bowel syndrome. Okay. Now this is a very different entity from IBD, which is inflammatory bowel disease, not the same as IBS, which is this, irritable bowel syndrome. So it's about 1 in 5 Americans suffer from it. It's more common in females than males, as we can see here. And stress, again, it seems to be an underlying theme causing flare-ups and all of these disorders. And what happens here again is indigestion and flatulence and cramps and diarrhea and vomiting and nausea and loss of appetite, okay? All of these things come to the fore with this disorder here. It's more of a diagnosis of exclusion. In other words, you don't right away diagnose irritable bowel disease in a person. You have to rule out all the other possible causes. Is it like intestinal obstruction or a peptic ulcer or inflammatory bowel disease or something like that? If you have ruled out all the other causes, how would you diagnose irritable inflammatory bowel disease anyway? Well, an X-ray, GI series in abdominal X-ray might show you some kinking of the intestines and possibly ulcers as well. Certainly an endoscopy where you put in a flexible camera, a fiber optic camera through the mouth and advance it all the way down into your stomach and then onwards into your intestines. You can see the ulceration there. Or you can take an intestinal biopsy, which you do with endoscopy. You take a small piece of tissue from the intestines, and then you make a slide of it, and then you can see the ulceration and the autoimmune damage there, okay? So if all of those causes have been ruled out, then you can diagnose irritable bowel syndrome in your patient. So it's a diagnosis of exclusion, okay? So treatment is equally non-specific. So is a diagnosis of exclusion. So treatment, as you can see, lifestyle modification, stress reduction, right? Altering diet, so different types of foods. So for example, you might be sensitive to gluten in your diet, and gluten, again, is a type of protein which is found in wheat and wheat-derived products, and some people are allergic to that. So you might discover that that is what causes your gut to act up. So you might want to stay away from that and go on a gluten-free diet and those kinds of things. Again, medications, anti-diarrhea pills, that is something that would help as well. All right, so the small bowel is where your food spends anywhere from 8 to 12 hours, depending on what type of food. So sugary foods pass the fastest, while the foods with the highest fat content, fatty foods, stay the longest in your intestines, okay? So most of your electrolytes, vitamins, and nutrients are absorbed in your small intestine. So let's start with the first part of your small intestine, which is called the duodenum. As you can see here, it starts at the pyloric sphincter, and then it makes a C shape, like a loop around the head of the pancreas. Most of your duodenum, the first part of the small intestine, is retroperitoneal. It is located behind the peritoneum, as we can see here. And that is quite an important region, because in that small region, there's quite a few important digestive organs all crammed together, right? You have your liver and the right hypochondrium, epigastrium as well. Then you have the gallbladder, then you have the duodenum, you have the pancreas, you have the spleen, all of those organs crammed in that area. So a lot of general surgery will be confined to that area, because there are so many of those organs which could possibly be involved with many different pathologies, different disease processes found in that area, okay? So jejunum is your next part, the second part of your small intestine. It's about 2/5 of the total length of your small intestine, okay? And this one is intraperitoneal. It is surrounded by the peritoneum on all sides. And then ileum is the last region of the small intestine. And the ileum ends into something called the ileocecal valve. And that is where the ileum continues onwards as the large intestine. Ileum is also intraperitoneal, surrounded by the peritoneum on all sides. Okay, so one thing that you will see as an outstanding histological feature throughout your small intestine is something called circular folds. And these circular folds, they act like speed bumps, as it says here. They slow down the passage of the food, and they increase the surface area available for absorption of nutrients from the food as well. So these speed bumps make sure that enough nutrients and electrolytes are absorbed from the food before they're allowed to pass on. Okay, so here you are taking a look at your small intestine. Here's the mucosa. The epithelium, of course, is the columnar, simple columnar epithelium is what you're seeing here, right? And then you have a lot of mucus-secreting goblet cells here as well. Then the muscular layers, the inner circular muscle and the outer longitudinal layer. We talked about those different types of smooth muscles. And then the outermost serosa And these are what those speed bumps, these circular folds look like. They slow down the passage of food and help with the absorption of nutrients. Also helping with the absorption of nutrients on, on a histological level are these finger-like projections called villi, as you see here. They are the most numerous in the jejunum, which is the second part of your small intestine, okay? And these finger-like villi actually, as we see here, increase the surface area available for the absorption of food stuff, okay? You also have a bunch of lymphatic capillaries which are found in this area called lacteals right here. And the lacteals, these lymphatic vessels in your small intestine, they absorb fat, lipids, and also lipid-soluble vitamins. So what are those vitamins which are soluble in fat? So remember the acronym CADE, K-A-D-E, CADE, CADE. These are the, so in other words, vitamin K, vitamin A, vitamin D, and vitamin E, CADE, lipid-soluble vitamins. They are also basically absorbed here in your jejunum where there's a lot of villi. Here, this is what villi look like. If you look at them, each of these finger-like projections, right? Those would be the villi, as you can see here, right here, small finger-like projections. And then you see lacteal is the lymphatic capillary. Lymphatic nodules are found here as well. Lacteals, they transport lipids from your food to the lymphatic system, okay? So you can see those structures here in this picture. Then microvilli are, again, uh, finger-like projections of the epithelium itself, which is the simple columnar epithelium here, okay? And they do the same thing as villi. They increase the surface area available for food to be absorbed, as you can see. And they also have certain enzymes which are called brush border enzymes because it looks like a brush, like a hairbrush, fingers projecting out of it, right? And so these enzymes which are found there help with breaking down food and in its absorption as well. So then these are the glands that are found within your intestines. And these glands secrete something called the intestinal juice. For example, goblet cells, they secrete mucus. Okay, goblet cells secrete mucus. Also, some other gland cells that secrete something called enteropeptidase. This is a protein digesting enzyme. And then endocrine cells, which release hormones like cholecystokinin or CCK and secretin. Remember those two hormones that cause your bile and your pancreatic juice to be secreted more and more. They increase the alkaline secretions in your small intestine. Why do they increase the alkaline secretions? Because the food that came from the stomach was acidic. There was a lot of acid from the stomach. So to neutralize that acidity, these are the alkaline secretions. So there, in this picture, you can see all of the different glands of your small intestine and what they produce, right? So here is your microvilli, the simple columnar epithelium protruding like fingers. Goblet cells secrete mucus. Unicellular gland cells synthesize enteropeptidase, and then these enteroendocrine cells secrete CCK and secretin, hormones like that. There's that lacteal, the lymphatic capillary in green. This lacteal reabsorbs lipids, fats from the intestine. Okay, so how does the intestine basically help with the mechanical digestion? So it's like a slinky. You know, if you've ever played with a slinky, to and fro motion, that's what your intestine does with the food, mixing it. And it also contracts. So the longitudinal muscle plays the slinky game to and fro, and your circular muscles contract your intestines, and that helps with the entire churning process. All right. And so there are cells within the walls of your intestines called the pacemaker cells, and they generate these electrical impulses at regular intervals to make your intestines churn the food all around. And so that's what you're looking at here. So then you have something called the gastroileal reflex, which means what? Your stomach, when it's full, right? When the stomach is full, it promotes the movement of food from the ileum into the cecum, right? From the ileum to the next part of the stomach, because the message is, okay, there's more food coming into the stomach, so let's move the rest of the food out of the way, so it moves on into the other parts of the small intestine. Okay, next up we are looking at our so-called biliary apparatus, which means everything that has to do with bile. So what is bile? Again, this greenish, bitter fluid synthesized in your liver and then stored in your gallbladder. Here's your gallbladder under the liver. This is bile. You see this greenish fluid here. The function of bile is to what? Emulsify fats. This is like your dish detergent. That's the best example I can give you. Even the color is greenish, like most dish detergents. And so what it does is it breaks down fats and grease in your food, breaks it apart into these globules that can easily be digested then, okay? So that's why people in whom you have removed the gallbladder, a procedure called cholecystectomy, they have to be on a fat restricted diet because the gallbladder is not there to concentrate and store and secrete bile anymore. So either they can take bile pills or they have to be on a fat restricted diet, okay? Those are the things that would prevent indigestion and flatulence and cramps in these people. So something that you see in a lot of people who have undergone cholecystectomy, which means removal of the gallbladder, cholecystectomy, you see something called uh, steatorrhea, okay, which means too much fat in their stools, in their feces, okay, steatorrhea. And why is that? Since they do not have the normal bile going, they are unable to absorb the fats and the grease from the food that they eat, especially the animal foods that they eat. So all of that fat passes on undigested, and it appears in their stools, in their feces. So that makes their stools extremely foul smelling and pale in color. And characteristically, when they go to the bathroom, the stool tends to float on top of the pot rather than sink. Normally, the stool sinks because it's heavier than water, but in cases of steatorrhea, fatty diarrhea, it tends to float at the top. Why? Because fats and oils are lighter than water. They're less dense than water, so they tend to float at the top. So this steatorrhea is something that you will see in people with gallbladder removal, okay? Uh, and the reason, of course, being the fat is not uh, reabsorbed and digested from their food, so it passes out as a whole in their feces, okay? So the question is, what types of people are more likely to develop gallbladder disease or cholecystitis, gallbladder inflammation, or gallstones, because gallstones themselves give rise to gallbladder inflammation, right? Cholelithiasis is what it's called. Cholelithiasis for gallstones, stones in your gallbladder. Cholelithiasis leading to cholecystitis, which is inflammation of the gallbladder, which might require a cholecystectomy or removal, surgical removal of your gallbladder, okay? So who gets gallbladder disease? Remember the 5 Fs, all right? The 5 Fs, so what do they stand for? The first F is for female, the second F is for fat, the third F is for fertile, the fourth F is for 40, and then the fifth F is for fair. Let's go over these risk factors one by one. Females are more likely to develop gallstones. Why? They have more estrogen. Estrogen seems to slow down the movement of your bile duct. So bile travels or gets secreted more slowly in females than males. So they're more likely to develop gallstones and gallbladder irritation. Fat, if you have too much cholesterol in your system, you don't have to be physically fat necessarily, but if you have a lot of animal fat in your system, cholesterol levels are high, you're more likely to develop cholesterol gallstones because of that. Fertile. So females who do develop gallstones are usually in the perimenopausal years. They are fertile. They're still fertile. The estrogen levels are still high, but they're more like 40-ish. So that's why the fourth F, 40, around 40 years of age is when you're more likely to develop gallstones. And fair, it's more common in Caucasians and white patients as compared to others for reasons unknown, okay? So remember the 5 Fs as the risk factors. All right, so let's take a look at the anatomy of your biliary apparatus. So the bile is flowing down here from your liver by means of the right and left hepatic ducts. Those two join together to form the common hepatic duct, which flows here. And then the gallbladder sends out its own cystic duct to join the common hepatic duct. And all together now it's called the common bile duct, as you can see. So the common bile duct runs just behind the pancreas here and then empties out into your small intestine, into your duodenum, at what is called the major duodenal papilla right here, okay? At the same time, you can see the head of the pancreas. Here's your pancreas. And you can see how the head of the pancreas is nestled nicely in between the C-shaped loop of your small intestine, of your duodenum here. So from the pancreas, you have this pancreatic duct, the main pancreatic duct running, actually, right? And so there's also an accessory pancreatic duct, a smaller one. And so the pancreatic duct joins up with the common bile duct to be secreting pancreatic juice and bile together by means of the major duodenal papilla into your small intestine. Okay, so that's basically what you're looking at here. So gallstones can form at any level. They can form within the gallbladder. They can form here in the cystic duct. They can even form here in the common hepatic duct or in the common bile duct. So whatever the case, if there's obstruction of bile duct, then bile does not get to your food, right? So you develop steatorrhea, fatty stools. At the same time, if the bile levels rise, that can also give you jaundice, okay? Because bile is also uh, needed for the absorption of bilirubin. Bilirubin is a breakdown product of of hemoglobin, of the heme, from the hemoglobin, right? So heme is broken down into this yellow substance called bilirubin, and bilirubin gets converted into something called biliverdin, which is green, and that gives rise to bile, right? So any obstruction of bile here, and that can also lead to elevated levels of bilirubin, which is the yellowish substance, and high levels of bilirubin or hyperbilirubinemia is what jaundice is all about. Okay, so something to remember here. Okay, so next up, we are looking at the liver itself. So let's take a look at the liver. So looking at the liver, you can see that it is divided into a much larger right lobe versus a smaller left lobe, okay, by means of something called the falciform ligament. And the falciform ligament contains the round ligament of the liver. Now, basically, this is a remnant of your umbilical cord. Think of it that way, right? So the remnant of your umbilical cord, once that was your lifeline to your mother's placenta. Um, so that is what is left here. And that divides the liver into these two lobes, as you can see. You can also see the inferior vena cava emerging from the top, from the posterior, the back side of the liver, and then your gallbladder also peeking out from the back here. So taking a look at the inferior surface of the liver, now you can see the gallbladder in its entirety. You also look at the hepatic portal vein here, which is an important vein, as we mentioned before, and we'll talk about a little bit more today. And then, of course, the the hepatic veins, and then what you have here is the hepatic artery. Okay, uh, so all of these taken together, the hepatic artery, the common hepatic duct, uh, as well as the hepatic portal vein, it's called the porta hepatis. The porta hepatis, as you can see here, is made up of these three important structures taken together. All right. Okay, what else do we have? So then again, you have a smaller lobe called the quadrate lobe here on the inferior surface of the liver, and then down below here, a caudate lobe. So quadrate and the caudate lobes, those two are also present on the inferior, the underside of the liver. And then of course, the much larger right and the left lobes. Here is your inferior vena cava in this picture as well, right? Okay, and then ligamentum venosum, which was once your umbilical vein, right? The umbilical vein